Hello and welcome to a post-recording of the November 2022 ICU Journal Club, where we discuss the Waterfall trial. The Waterfall trial pertains to the acute management of pancreatitis in regards to fluid resuscitation. Before we get into the article, I'd like to go through some quick background on the topic. Pancreatitis is the leading GI cause of hospitalization in the US, so it's relatively common. Moderate to severe pancreatitis develops in 20 to 35% of all cases, and mortality can range anywhere from the average of 5 to the increasing in severity of necrotizing pancreatitis, with mortalities up to 17%. As we all know, pancreatitis is an inflammatory condition. It's characterized by capillary leak, third spacing, dehydration, GI loss. So there is and has been a concern for a combination of underperfusion and edema to cause an increased risk in necrotizing pancreatitis, and with that, increasing worsening outcomes and mortality. Due to this concern, guideline and expert-driven recommendations for fluid resuscitation is as follows. Bolusing 10 to 20 mLs per kilo of crystalloid fluids in the case of pancreatitis, lactate at ringer, and starting maintenance IV fluids from 250 to 500 mLs an hour for 12 to 24 hours. And for brevity's sake of Journal Club, we all need to understand that fluid overload and excess is bad. This is in regards to both pancreatitis and critical illness. So now let's moving on to the article that we're reviewing today. This was posted in the New England Journal of Medicine, September 2022. The title of the article was Aggressive or Moderate Fluid Resuscitation and Acute Pancreatitis. The clinical question being, in adults with acute pancreatitis, does aggressive fluid resuscitation compared to moderate fluid resuscitation result in a reduction in the development of moderately severe to severe pancreatitis? Let's elaborate on the clinical question with a PICO format. The patient population is mild acute pancreatitis patients that are adults and presenting to the emergency department. This is a key vital portion of understanding this article. The patient population is mild acute pancreatitis. The intervention is moderate fluid resuscitation, and this was defined as bolusing the patient 10 mLs per kilo of crystalloids, i.e. lactate at ringer, in a patient that was hypovolemic. Patients that were not hypovolemic did not receive a fluid resuscitation, and all comers received maintenance IV fluids of 1.5 mLs per kilo per hour. C would be the comparator or the control. This was aggressive resuscitation. All patients received a bolus of 20 mLs per kilo of crystalloids, and then they were started on maintenance IV fluids at 3 mLs per kilo per hour. The outcome they were looking at was the development of moderate severe pancreatitis. So essentially they were looking for the mild acute pancreatitis population that converted over to moderately severe to severe pancreatitis. Moving on to the design and method, this was a multi-center, actually a multinational randomized controlled trial, meaning that the subject is randomized to go into 1 to 2 of the treatment arms within the paper. And then lastly, this is a superiority trial. To be very clear, they were looking to show that moderate resuscitation was better than aggressive resuscitation. The patient population was comprised of 18 centers from India, Italy, Mexico, and Spain. These were less ill patients than what the critical care folks are used to, so everybody was able to offer handwritten consent. There was a 1-to-1 assignment to aggressive versus moderate fluid resuscitation. And lastly, I'd like to reiterate that this study was unblinded to both patients and investigators. I'd like to point that out because one of the scoring system is a patient-driven subjective scoring system. This would be the PAN-PROMIS scale. Now let's look at the inclusion criteria of the paper. And essentially these were acute pancreatitis patients, mild acute pancreatitis. They used the revised Atlanta classification, and just to reiterate what that is, you need to meet at least 2 out of the 3 of the following: typical abdominal pain, an amylase or lipase that's 3 times greater than the upper limit of normal, and or evidence of pancreatitis on imaging. You had to be an adult, you had to present to the emergency department, and your presentation to the emergency department had to be within 24 hours of pain onset. Also with that, you need to be enrolled within 8 hours of diagnosis of pancreatitis. Let's take a look at the baseline characteristics. So there's some mild inequalities here as you can point out in the yellow highlight. There's more females in the aggressive fluid resuscitation, and there's also more gallstone-related pancreatitis in the aggressive fluid resuscitation. Now in the green highlight, what I'm trying to point out is that these are not very ill patients at all. I'm not overly familiar with the median Charleston comorbidity score, but I did look this up. A score of 2 is very low. We all should be familiar with the BISAP score for pancreatitis. A score of 1 is very low. And then lastly, this median PAN-PROMIS score. I think it's important to talk about this for just a moment. This is a 7-item scoring system in which the patient rates their severity between 1 to 10, 1 being barely anything and 10 being the worst. The items, the groups would be pain, abdominal distension, difficulty eating, difficult bowel movements, nausea and vomiting, thirst, and weakness. So essentially 7 groups. The highest score would be 10 in each group. So the highest score you can get from the PAN-PROMIS scale or scoring system would be 70. So an average of about 29 is not that high. Now let's take a look at the exclusion criteria, and I made particular attention to put them all down on the slide on purpose. There's an extensive exclusion criteria here. So one, the most important, if you were already meeting criteria for moderately severe or severe pancreatitis at baseline, you were excluded from this trial. And inherently saying severe pancreatitis, you were not in shock and respiratory failure or in renal failure. If you had bad decompensated heart failure, you were excluded, hypertension, and I think one of the most important items to point out here is the electrolyte abnormalities. Hypernatremia, hyponatremia, hyperkalemia, and hypercalcemia. And even the numbers they use for cutoffs here are very mild. And in hyperkalemia, this is barely even categorized as hyperkalemia. Next would be life expectancy less than 1 year, chronic pancreatitis, chronic renal failure, decompensated cirrhosis, and then on presentation during randomization, any clinical signs of fluid overload or heart failure, you were excluded. And then we already discussed time for pain onset to arrival at the ER had to occur within 24 hours, and also you need to be randomized within 8. Now taking a look at the study flow chart, 676 patients were assessed for eligibility. They excluded 427, and this left us with a net of 249. This 249 was the first third of enrollment goal, and this triggered the first planned interim analysis. Taking a look at the exclusion group up here, there's 427, and with the exception that there are a lot of exclusion criteria, nothing looks out of the norm here. I'll point out there's really only 3 patients that were lost to essentially error. It's stated as technical problems with randomization program. Now let's take a look at the intervention and control groups. So essentially, we were randomized 1-to-1 fashion to either aggressive fluid resuscitation group or moderate fluid resuscitation group. Again, in the aggressive fluid group, you were bolused with 20 mLs per kilo and started on maintenance fluids at 3 mLs per kilo per hour. Again, this is crystalloid. Again, this is lactated ringer. If you were in the moderate fluid resuscitation, you would only receive a bolus of 10 mLs per kilo if you were deemed to be hypovolemic. We'll discuss what the criteria was to deem a patient hypovolemic in just a moment. And all comers were starting on maintenance IV fluid at 1.5 mLs per kilo per hour. I think this is easier to put in a real-world concept, so I used myself. I'm your patient today. If I was enrolled in the aggressive fluid resuscitation group, you would give me 1.72 liters of a bolus and start me on 258 mLs per hour of maintenance IV fluids. If I was in the moderate fluid resuscitation group, only if I was deemed to be hypovolemic, you would administer 860 mLs bolus and start me on maintenance IV fluid at 129 mLs per hour. Next, at the 3-hour mark, there's a safety checkpoint. So if there was suspicion of fluid overload, the fluids could be decreased or stopped. And again, we'll go over their definition of fluid overload and what they use for their criteria in that. Lastly, in these green boxes down here, there essentially was biochemical and physical assessments done at the 12-hour mark, 24, 48, and 72-hour mark, and these were deemed as their goal-directed therapy checkpoints. Now, there's a lot of data in these green boxes. Let's go ahead and blow this up a bit and discuss this. So first, let's get out of the way their definition of hypovolemia. The patient needed to meet one or more of the following criteria: a creatinine greater than 1.1 or a BUN greater than 20, and or an increase from the previous values in creatinine and BUN, a hematocrit greater than 44%, urine output less than 0.75 mLs per kilo per hour, a systolic blood pressure less than 90, or signs of dehydration. And this could be subjective complaint for thirst. It could be also physical assessment with mucous membrane assessment and skin turgor. Just to reiterate, on the left side, this would be our aggressive fluid resuscitation group. And if you were hypovolemic at 12, 24, 48, or 72 hours, you could get another bolus of 20 mLs per kilo crystalloid, and then continued on your 3 mLs per kilo per hour of maintenance IV fluid. If you were normal volemic, your IV fluids were turned down to 1.5 mLs per kilo per hour. And if there's suspicion of fluid overload, the IV fluids could be decreased or stopped. And in the supplemental, you can find the patients were also giving diuretics. Now, if you were over in the moderate fluid resuscitation group at 12, 24, 48, or 72 hours, and you were found to be hypovolemic, you could get another bolus of 10 mLs per kilo and continued on your maintenance infusion at 1.5 mLs per kilo per hour. If you were normal volemic, you were continued on your maintenance IV fluid at 1.5 mLs per kilo per hour. The next thing I would like to point out here is oral feeding. So oral feeding was started at the 12-hour mark if the PAN-PROMIS scale was less than 5. And again, that PAN-PROMIS scale goes into assessing abdominal pain, abdominal distension, nausea and vomiting, their ability to take something PO. So a score less than 5 is pretty low. So if their score was less than 5 at the 12-hour mark, they were allowed to start on oral feeding. In the aggressive group, the maintenance IV fluid was stopped after 48 hours if oral feeding was tolerated for greater than 8 hours, where in the moderate fluid resuscitation group, the infusion was stopped after 20 hours if oral feeding was tolerated for 8 hours. So essentially what we're saying here is that maintenance IV fluids were continued much longer in the aggressive fluid resuscitation arm than it was in the moderate. So what was our primary outcome? So our primary outcome was the progression from acute mild pancreatitis to moderately severe to severe acute pancreatitis. And how did they classify the varying severities of pancreatitis? Well, again, they used the revised Atlanta classification. So the mild acute pancreatitis folks had no organ failure and no local complications, where the moderately severe acute pancreatitis patients had local complications and or systemic complications and or transit organ failure. So examples of local complications would include peripancreatic fluid collections or necrosis, and then examples of systemic complications would be exacerbations of pre-existing conditions, or a creatinine greater than 1.9, a systolic blood pressure less than 90, or a PF ratio less than 300. And lastly, the definition of severe acute pancreatitis was persistent organ failure greater than 48 hours. Now let's look at our main safety outcome. It would be fluid overload after randomization during the hospitalization itself. And how did they define fluid overload? Well, the patient had to have at least 2 out of the 3 following. They had to have symptoms, physical signs, or imaging. The symptoms were a subjective complaint of dyspnea. Physical signs were edema, rales, JVD, or hepatojugular reflex. The authors made very particular discussion points to have us understand that to ensure reproducibility, heart sounds, effusions on chest x-rays, and orthostatic variables were not used in this process. They felt there was too much subjectivity in some of those assessments. I looked into the supplemental to understand why they excluded effusions on chest x-rays, and their explanation was because they were fearful that in pancreatitis, the majority of the effusions would be exudative, as opposed to transudative, which would more indicate fluid overload. And lastly would be imaging. So examples of imaging would be echo findings, chest x-ray findings, and some patients actually had left and right heart catheterizations. In addition, they split fluid overload into 3 different severities: mild, moderate, and severe. So mild was responsive to therapy. So that definition was they responded to either decreasing the IV fluids or stopping it. And in addition, patients were given diuretics. Their PF ratio was always above 300. Where in moderate, the patient was still responsive to therapy and their PF ratio dropped below 300 at least once. And then lastly, severe fluid overload. Their definition was the patient needing mechanical ventilation or some type of renal replacement therapy. Exploring some further secondary outcomes, there are many, almost too many to report on a quick webinar brief summary of a paper. I will point out these were pre-specified secondary outcomes, which are important, but at the end of the day, these are hypothesis-generating findings. Looking at the stat analysis of this paper, I'd say they did a very good job explaining their statistical methods throughout the paper. I debated adding some of this discussion within this webinar. However, I think for time's sakes, this wouldn't be possible. Plus, I don't think anybody would watch any further journal clubs. So I really wanted to focus on some things that I felt were very important. Again, well-documented section on stat analysis. What I'd like to spend a little time on is how they got their power analysis and how this is going to play into our critique of this paper. They had anticipated baseline primary outcome of 35%, meaning they anticipated their mild acute pancreatitis patients converting over to moderately severe to severe about 35% of the time. And they got this assumption from a previous paper in 2019. So they were able to calculate a sample size of 744, and this meant 372 patients to each arm. With that, there was 80% power to detect a 10% difference, meaning if they assumed a 35% conversion over from mild to severely moderate to severe with aggressive fluid resuscitation, they were hoping to show a difference with moderate fluid resuscitation to be about 25, so a 10% difference. Two-sided significant level of alpha 0.05, which we're used to historically in medical research. This would give us about a 5% risk of the probability of rejecting a null hypothesis when it's actually true. In addition of importance, there was 2 pre-planned interim analysis, one at a third of enrollment goal and a second at 2/3 enrollment goal. And they had 3 a priori stops designed within their paper. One would be essentially a significant difference between the intervention and control, meaning there was just overwhelming evidence at the interim analysis that one arm was better than the other. Second would be clear evidence of harm in one trial arm over the other. And lastly would be slow enrollment. Now let's take a look at the results. Again, there were 676 patients screened. Of that, a total of 249 patients met inclusion criteria. The first interim analysis was at a third of the enrollment. That was 249 patients. Unfortunately, the trial was stopped early due to interim analysis identifying a signal for harm. But most importantly, along with that signal for harm, there was no significant difference in the primary outcome, which was a development of moderately severe or severe pancreatitis. The numbers are listed here, 22.1% in the aggressive arm versus 17.3% in the moderate resuscitation arm. 95% confidence interval. The confidence interval crossed 1, so there's no difference in either groups, and the p-value was 0.32. Lastly, in the results section was a much higher incidence of fluid overload between the two treatment arms. So in the aggressive fluid resuscitation arm, 20.5% of the patient population reached a definition for fluid overload, where in the moderate fluid resuscitation arm, only 6.3% did. Interesting to point out the total fluid received during the first 48 hours. In the aggressive group, there was a mean of 7.8 liters with a range of 6.5 to 9.8 liters. And in the moderate resuscitation group, there was a mean of 5.5 liters with a range of 4 to 6.8 liters. To summarize the results, there was no significant difference in the primary outcome, and there was a much higher incidence of fluid overload between the two treatment groups. In addition, these multitude of secondary outcomes, while we can't really make statistical sound judgment with some of these results, there's very strong trends towards favoring moderate versus aggressive fluid resuscitation, as you can see here. So what are the strengths, in my opinion, of this paper? It was a very relevant, applicable clinical question. It was a one-to-one parallel design, as we discussed prior. It was also an intention to treat analysis. What that really means that all participants that were randomized were included in the statistical analysis. This was a multi-centered, actually multinational randomized controlled trial. There was no loss to follow-up. There was pre-specified secondary outcomes, and there was a priori interim stopping rules. Now let's look at the limitations of this paper, in my opinion. The biggest thing to go over is that this is an underpowered trial. The paper was stopped due to risk for harm. Next, these are not critically ill patients. The majority of folks listening to this right now are used to taking a look at literature and papers on critically ill patients. These were not critically ill patients. And I started this because it's not necessarily a limitation or a fault of the authors, but it's just something I want out there. In one breath more, though, these patients aren't even that sick when we take a look at some of these things. And one of my criticisms of the paper is that the exclusion criteria is so strict. This is an open label trial, so obviously there's risk for bias. There's a good amount of subjectivity built into the flags for fluid overload, especially the clinical exam. And then lastly, all markers or criteria for hypovolemia are not great markers for fluid responsiveness. And again, I star this, not a fault to the paper, the investigators, the authors. These were essentially floor patients, so nobody was pulling out non-invasive cardiac outputs or stroke volume measurements, or for that fact, POCUS at bedside. The baseline characteristics were okay balanced, and then I'll point out that this multinational paper really had nothing to do with the US. It was Italy, Mexico, India, and the mass majority of these patients were pulled from Spain, so you always have to question the applicability to our patient population. And lastly would be the sample size calculation. I think we need to take a moment to discuss this. The sample size calculation was based off of an assumption of 35%. And again, that 35% was pulled from a previous study, and that was the assumption that 35% would cross over into the moderately severe to severe pancreatitis criteria. But in actuality, in this paper, it was only 22.1%. This raises some flags, and it really has to do with effect size. If the actual rate was 22.1%, one would say you probably have to have a smaller detection in difference. So instead of an ability to detect a 10% difference, it's probably going to have to be much lower. So in this case, you probably would need to have a much larger sample size to detect that 10% difference. So it might be too large of a goal or target. So what was the author's conclusion? Well, they said early aggressive fluid resuscitation resulted in a higher incidence of fluid overload without improvement in clinical outcomes. I would tend to agree to this. Additional takeaways that I had, my opinions, were I still do not believe that we should be adhering to guidelines from 2013 that really regard aggressive overzealous fluid resuscitation. I still strongly feel that we should not blindly administer fluid whenever possible fluid responsive testing should be done. I feel that there's already clear signals in the critical care literature that too much fluid is bad. And then lastly, while this trial doesn't do much from a statistical significance standpoint, it adds to the pile of really red flag to tell me not to overly aggressively fluid resuscitate my patient. Now, if we were all sitting down together in person, we would now have a group discussion, and obviously we're not able to do that at that time, but if you have any questions, concerns, or most importantly, input, please feel free to reach out to me at rgibson2@chsbuffalo.org. Thanks so much for your attendance.